Thank you, Meryl. So I'm Beth Rose. I'm here with one of the co-founders I'm one of the co-founders of the Alaska Eating Disorders Alliance, and I'm here with the other co-founder, Jenny Loudon, who will speak in a couple minutes. And we just really appreciate being here today. We're excited to join you to talk about eating disorders, what to look for, some foundations of treatment, and a little bit about local resources. And we'll have time to answer questions at the end. So the Alaska Eating Disorders Alliance, which we also call AKEDA, is an Alaska 501c3 nonprofit that Jenny and I co-founded, and both of us have lived experience. We both had eating disorders as teens, and I think we would both say we were in a really dark place when we had our eating disorders, but we didn't really know it then. They talk about a 4-letter word with eating disorders, and that's being fine. And so we thought we were fine, at least for now. I guess I could say, looking back, I really thought that my brain was hijacked. All my emotions were numb. And fortunately, both Jenny and I on our own separate journeys were able to recover fully. And neither of us would have gone on to do this work had we not had a family member who experienced an eating disorder. And we didn't know then that there's a very high genetic predisposition for eating disorders, like many other mental health issues. And navigating the challenges associated with finding treatment and support in Alaska was incredibly difficult. And a lot of that was because of all the shame and stigma that surrounds eating disorders, just around all mental health issues. So we came together with the hope that we could start an organization that would help others have an easier path, an easier time of walking that path, and not have to have that journey alone. So today, AKEDA is governed by 9 board members that reflect the voices of individuals in an ideal treatment team, including a doctor, a therapist, a psychiatrist, a registered dietitian, a wellness coach, people with lived experience, and Jenny and myself, who both have backgrounds in nonprofit management, fundraising, and health policy and community engagement. So we are a statewide organization, and we have board members and volunteers from Juneau, Sitka, Fairbanks, Utqiagvik, Kenai, Mat-Su, and Anchorage, so really around the state. Our mission is to provide help and inspire hope by engaging our diverse communities for Alaskans affected by eating disorders. And we do that by offering education, support, and advocacy. And then through our various activities, we also promote body confidence programs to help prevent eating disorders. So we like to start our presentations with some basic information about eating disorders, so everyone has the same basic knowledge when we start out. And the first thing to know is that eating disorders are serious, and they may be life-threatening. In fact, they have the second highest mortality rate of any mental illness, only behind opioid addiction. Nationally, every 52 minutes, someone dies as a result of an eating disorder. And this is due to the physical impacts of the eating disorder on many body organs that are affected, as well as extremely high rates of suicide. And people with eating disorders aren't just dieting. They're experiencing extreme anxiety around weight gain, calories, food, or body size. And these anxieties around food and weight may take up to 90% or more of their thinking. You could even say 100% if they can't sleep well at nighttime, and this is ruminating on this, even not being able to sleep. And so that focus, that constant attention to weight and food really can interfere, as you can tell, with the ability to function at school, at work, or with their home life. So a diagnosis of an eating disorder is a real crisis, and it impacts both the individual and the family. And some people still have sort of an older belief that eating disorders only impact a certain subsect of the population. Specifically, they think about eating disorders affecting privileged white teen urban girls. And it's really a stereotype that doesn't hold up when we do the research. What we find is that eating disorders do not discriminate. They affect men, trans people, people of color, older people, young children from even the age of 6, people with disabilities, really people from every walk of life. And from a gender perspective, we know that men make up about 30 or 33% of eating disorder diagnoses. And in terms of age, as I mentioned, there are children as young as 6 who are diagnosed with eating disorders. And that can just extend throughout someone's life to 70 plus. So there was a study that was conducted before the pandemic that said that 9% of people who are alive today will experience an eating disorder in their lifetime, or 30 million Americans. And then extrapolating from those statistics, we estimate that more than 65,000 Alaskans will experience a clinically diagnosable eating disorder. And this is actually just looking at what can be diagnosed in the DSM-V. There's like sub-threshold eating issues, which is like constant dieting and such. We'll talk about that a little bit later. And that's not included in these numbers. The study behind the numbers of the 9% of people living today who will have an eating disorder, that was conducted pre-pandemic. And that was before what we're calling now a true mental health crisis in our country. The National Eating Disorders Association reports that they experienced calls to their hotline that doubled after the pandemic started. And hospital admissions for eating disorders have also been on the rise, with many of those people seeking help at higher acuity levels than ever before. And the rate of providers seeing eating disorders has never been higher. So, as I mentioned on the last slide, eating disorders don't discriminate and occur in all ethnic groups. And I wanted to share just a little bit about what we know about eating disorders in Indigenous populations, since that's an important demographic here in Alaska. And we absolutely need more research in this area. But the data that we do have paints a highly concerning picture. So several studies indicate there may be a higher prevalence rate of eating disorders within Indigenous populations than the general population. And findings also show rates of risky eating behaviors and body dissatisfaction. And yet, Indigenous people are less likely to be diagnosed, often because of stereotypes about what eating disorders look like. So you can see some of the findings from these studies on the slide. For example, you can see Indigenous women in the US are more likely than white women to experience episodes of disordered eating, but less likely to be properly diagnosed. 48% of Indigenous adolescents were trying to lose weight, higher than any other ethnic group. And Indigenous women who are more acculturated to mainstream white culture are more likely to show symptoms of anorexia and bulimia than Indigenous women who are less accepting of that. So it's clear that helping individuals, especially young people, stay connected to their cultures, including their own cultural appearances, may provide an important protective factor against disordered eating. The positive thing is that while eating disorders are serious and life-threatening, they are treatable, and people can achieve full recovery, as Jenny and I can attest to. So people can recover from eating disorders at any stage of the illness, even after lengthy battles. And so that said, research shows that the best predictor for full recovery is early and intensive treatment. So responding to eating disorder symptoms within the first 3 years of onset. And you can see why we encourage therapists, doctors, family members, and friends to actively respond to behaviors and physical changes that might indicate an eating concern, because early intervention can save lives. So I'm going to turn the presentation now over to Jenny.
Great. Thank you, Beth. So now that you can understand the importance of early intervention, you can see why it really is so imperative to learn the signs and symptoms so that you know what to look for, and you can then hopefully respond more quickly if there's a problem. So in this section, we are going to look a little bit more at some of the most common types of things that you might see, either in behavioral changes or maybe on physical exam. And we'll also discuss a little bit some of the differences between eating disorders and disordered eating. So we do find that a good way to start this conversation on eating disorders is to think about the full spectrum of eating behaviors, because this really can help answer one of the most frequently asked questions that we receive, which is, what is the difference between an eating disorder and disordered eating? So what we like to do is think about eating where you have, on one end of the spectrum, you have what we might call normalized eating. Normalized non-disordered eating. And in that space, a person is able to eat food when they're hungry, but they're also able to stop when they're full. In that space, a person is mostly able to accept their body as it is. They may not love everything about it, but they also don't feel a lot of anxiety or a desire to feel like they need to constantly be able to be trying to change it. In that space, they're also able to enjoy a wide range of food groups and do so with pleasure. And then at the far other end of the spectrum are eating disorders, and we'll talk about those soon. But you can see that in between those two areas of the far ends of the spectrum is this middle section where we really do see disordered eating behaviors. It can show up really in a lot of different ways. It might include frequent dieting, yo-yo dieting, fad diets or cleanses. Sometimes it shows up as intermittent fasting or chronic weight fluctuations. Sometimes it's rigid rituals around either food or exercise. And it really can be sometimes difficult to know what is the difference. Where does this disordered eating really tip over into an eating disorder? And so if you are working with patients or maybe with a loved one, it can be really helpful to think about kind of starting the conversation by asking a couple of really simple questions. Some things that might help are like, do you eat differently when you're by yourself or when you're with others? How much time do you think about food or your body? And how much is food or exercise impacting your life? And it really can be difficult to see that where that line is between the eating disorder and eating disorders. And what we'd like to say is that even if somebody does not meet the clinically diagnosable, requirements of the DSM to meet the diagnosis of an eating disorder, people that are in this middle category of disordered eating, they really still may be suffering, and they may really benefit from getting nutritional and psychological help. What we do know is that people who are engaged in those disordered eating patterns are at higher risk for developing a fully diagnosable eating disorder. So there are 8 different types of eating disorder diagnoses that show up in the DSM-5, and we will not try to discuss all of them today, which I'm sure you're all happy to know. It's a lot of eating disorders to talk about. But what we will talk about are really the 3 most common types of eating disorders, which include anorexia, bulimia, and binge eating disorder. And we're going to be talking about each of them based on their diagnostic criteria, what's required for a diagnosis. But it can make it appear when we do that sometimes that these show up as like a silo, that they will show up exactly as we state. But what we like to inform folks of is that really it's both possible and honestly quite common that you might see an individual showing up who's experiencing more than one type of eating disorder, either both at the same time, or maybe they might recover from one kind of eating disorder and then relapse with another. So while we talk about these and we'll talk about specific diagnostic criteria, do know that they often show up in much more complex and complicated ways. So anorexia nervosa, it's really the first thing people think about usually when they think about an eating disorder, even though it actually has the lowest prevalence rate among all of the eating disorder types that we will be discussing today. Anorexia is primarily characterized by self-starvation. And so you can imagine that as a result of that, it does have the highest mortality rate of all of the eating disorder types. That's a result of both the physical impact that malnutrition plays on the body, as well as very, very high suicide rates amongst those who are experiencing anorexia. So what happens is that somebody with anorexia, they just simply do not consume an adequate amount of food that would allow for normal body functioning. So eventually, over time, this can really play a major impact on pretty much every physical major organ and body system. We've heard a very well-known national speaker say, no body system gets by unscathed with anorexia. However, even while the individual might be objectively experiencing this abnormally low body weight, they usually also will have this intense fear of gaining weight and really a distorted perception of what their weight really is. It's one of the most frightening and confusing parts of this illness. Is that the person who experiences the symptoms generally really lacks the ability to appreciate the severity of those symptoms. So the clinical term that's used for this is anosognosia. That's defined as the inability or the refusal to recognize a disorder exists, even when it is clinically evident. So you can imagine that as a result of this anosognosia, somebody might be at an extremely low body weight. They may be severely malnourished and yet still believe that they're fat. And it can be like looking in a distorted mirror at the funhouse, where they look in a mirror, they see one thing, but it's not really accurate compared to what anyone else would see in reality. And so because of this, it can be sometimes difficult to help somebody understand that their problem is serious and that they need to make changes to their eating patterns or exercise behaviors. So what are some of the warning signs that you might see that might be clues that there is a restrictive eating disorder present? Well, you'll want to look out for some things like dramatic weight loss. And I will say that even if the person starts at a higher level weight, and we'll talk about that more, but weight loss, you do not have to necessarily look malnourished and look like a very small individual in order to be diagnosed with an eating disorder. There's usually a preoccupation with weight, food, calories, and dieting. Also a refusal to eat certain foods, progressing to restrictions against whole categories of food. What we often see is someone might start with very wide sections of foods, but over time, as the diagnosis becomes more dire, they become more and more restrictive, where it's fewer and fewer and a narrower number of foods that are considered safe. There's often consistent excuses to avoid meal times or situations involving food, and withdrawal from usual friends and activities, and also sometimes extreme exercise. And in addition to anorexia nervosa, there's also a differential diagnosis, which is called atypical anorexia. And although it sounds strange, it's actually much more common than anorexia. So somebody with atypical anorexia will experience all of the same behaviors, the same thought patterns as somebody with anorexia. And really the only difference is that they don't appear visibly emaciated. Actually, they don't even have to be considered underweight at all. It's important to note that for atypical anorexia, BMI is not a diagnostic criteria. So people with atypical anorexia, they can still be very, very ill, but they're often missed because they may not be visibly or medically underweight. Still, they experience a double death rate compared to age-matched peers, and they often feel like they don't deserve treatment because they don't look like somebody that what society expects somebody with an anorexia to look like. So researchers have been looking into why it is that people with atypical anorexia do have such a high death risk, since it used to be that people thought it was only based on BMI that caused the big medical risk. And what they're finding is that a big portion of the medical risk is based on weight suppression. And so that's not just the weight itself. So what that means is that if somebody loses a large amount of weight in a short period of time, it's that weight suppression that causes the medical risk, not just weight itself. So there was a really thorough, great article about atypical anorexia that was in the New York Times in October. It's really worth reading. The headline was, "But you don't look anorexic. New research shows that our assumptions about eating disorders are often wrong, and many people in larger bodies are starving themselves." So let's talk about some of the things that might be seen on physical exam for somebody with either anorexia or atypical anorexia. So oftentimes patients will grow lanugo hair, which is a soft, feathery hair. It can grow really throughout the body, and the purpose of it is to provide insulation. Nails often become brittle and dried out. Patients generally report that they feel very, very cold. And in fact, if you are doing a physical exam, you might feel their extremities and you'll be able to feel exactly the spot where the cold shows up. In severe cases, organs may begin to fail. Usually the kidneys, liver, and heart are the three organs that tend to go first and show problems. You may notice on a physical exam weight loss. So we know that for anorexia nervosa, there is a BMI requirement. So in order to meet the diagnostic criteria for anorexia nervosa, Somebody needs to be at a BMI of 17.5 or less. But as we spoke about with atypical anorexia, there is no BMI criteria for atypical anorexia. So what we really encourage you to think about is any weight loss of more than 15% of a person's normal body weight, it really deserves further investigation. And any major changes in a child or adolescent's growth chart really can be reason for alarm. And I'll turn it back over to Beth. Oh, you're on mute.
Okay. So bulimia nervosa is primarily characterized by binge eating, accompanied by compensatory behaviors, otherwise known as purging. And a simple way of thinking about this is someone who experiences episodes of excessive eating where they feel completely out of control, and then follow up with that excessive eating by using inappropriate methods of weight control to make up for that. So that might include vomiting, laxative abuse, and excessive exercise. And concern with body weight and shape and intense feelings of shame are also symptoms. And many people who are struggling with bulimia appear to be of an average weight. So it's important to keep in mind that you really cannot tell if someone is living with an eating disorder based on their weight or their size alone. So some of the warning signs of bulimia nervosa are frequent trips to the bathroom after meals, an excessive exercise regimen with this compulsive need to burn off the calories taken in, even if somebody has an injury, withdrawal from usual friends and activities, large amounts of food may be missing from the pantry, or food wrappers and containers, a large amount may be found in the trash. There may be larger than normal amounts of money spent on food, and there could be secret stashes of food. Some signs of bulimia may be visible from a patient exam, and some patients will develop calluses on the dorsal side of their hands from frequent and chronic self-induced vomiting. This may also cause severe dental erosion and a higher number of dental caries or cavities. And so it's not uncommon actually for a dentist or a hygienist to be the first to be aware that somebody may be experiencing bulimia. And esophageal erosions or tears from self-induced vomiting is rare, but that also occurs. And if that does take place, that could be life-threatening. Like anorexia, some patients with bulimia will develop that soft lanugo hair. Others will develop enlarged parotid glands, and that can have the effect of giving someone the look of having chipmunk cheeks, and that can be caused from an increase in saliva production due to vomiting multiple times a day. Patients with bulimia also have electrolyte disturbances and may have heart rate abnormalities. Electrolyte changes, in fact, are quite common and are potentially life-threatening. So any patient with these purging behaviors should be monitored because of the potential lethality, and labs can change quickly. So it's important to really be tracking a patient. Binge eating disorder, which we don't talk about a lot, is actually the most common type of eating disorders. And in fact, it's 3 times more common than anorexia and bulimia combined. It's also more common than breast cancer, HIV, and schizophrenia. So binge eating disorder is characterized like bulimia with recurrent binge eating episodes, but without the compensatory measures to counteract the binge. So people with binge eating regularly eat more food than most people would in a single sitting, and they feel out of control when they're having that eating episode, and they have a lot of shame when this takes place. It happens at least once a week for 3 months or longer. And some of the warning signs about binge eating, and this is similar to, some of them are similar to bulimia, secretive about eating or their binge episodes, repeated episodes of dieting or attempt at weight loss. So somebody may actually be dieting, during the daytime or for a couple of days in a row, and then feel out of control because our bodies just biologically need to eat. So by that point, it may become a binge. Large amounts of food may be missing. And then food wrappers and food wrappers and containers may be found in the trash. Again, larger than normal amounts of money may be spent on food. There could be secret stashes of food. And then, just like we said, that you can't tell by looking at someone if they have an eating disorder, it's actually the same thing with a binge eating disorder. So you don't have to be overweight in order to be diagnosed with binge eating disorder. You can have anorexia and binge eating disorder at the same time. Again, if you severely restrict the food and then give in to hunger and binge. It's also important to note that people with eating disorders often have co-occurring mental health concerns. And research shows that 56% of those with anorexia meet criteria for at least one other mental health diagnosis. That number goes up to 95% for people with bulimia. So there's a saying in the field that eating disorders rarely ride in the car alone. There's almost at least one other mental health disorder riding along as a passenger in the car, and sometimes that car is full. So common coexisting conditions include mood disorders, anxiety, substance abuse, PTSD, OCD, and self-injurious behaviors. Research finds that recovery rates improve when treatment takes place for their eating disorder and for the co-occurring illness. So it's not just if somebody has OCD or substance abuse or anxiety, you can just treat that. They really have to be treated together. So we're going to just quickly take a look at how to identify and treat eating disorders. And there are multiple tools to screen for eating disorders. One of the quickest tools that's available is the SCOFF. And it's a very simple one. As you can see, this was developed in the UK, and you can see why in a minute. But basically, you can ask these 5 questions. Do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone, or could be 13 pounds in weight over a 3-month period? Do you believe yourself to be fat when other people say you are thin? And would you say that food dominates your life? So this has been around for about 20 years, and a score of 2 or more indicates a likely case of anorexia or bulimia, not quite as good at assessing for other eating disorders. And there's many other tools that can be used. And there's the Expert ED, which includes these questions along with some motivational interviewing language and resources. And that's listed on our website. So actually, if you're doing a screening with somebody and you're wondering about how do you follow up? What if somebody says something? The Expert ED, which is on our website, actually gives that language to you. There are other validated tools, including the EDEQ, the EAT, and the Binge Eating Disorder Screener 7. And we can share those if that's of help to you all. But whatever screening you use, it's really important. We were reminded about the most important thing about screening that was stated in Academy for Eating Disorder presentation. And a doctor said, the most effective screening device probably remains the provider even thinking about the possibility of an eating disorder. So that means whatever screening tool you might use, the most important thing is developing an awareness and a curiosity that would move you towards considering whether eating disorder concerns exist. Part of the assessment process is also seeking to determine the appropriate level of care for the patient. And the goal is always to provide services in the least restricted level that's appropriate for the patient. So as you can see, there's 5 levels of care. Going from the top on down, with inpatient, that's the highest level of care. And that's where services are provided in a medical hospital. The main focus is medical stability. That can be required when patients are severely low weight, when they've become medically compromised, or they're high risk for refeeding syndrome, which is a potentially fatal side effect that can happen when a starved person begins to take in nutrition again. The next level down is residential treatment, which includes 24/7 medical and behavioral health monitoring, and that includes frequent sessions with therapists and nutritionists, and also supervision over meals and movement. The goal at this level is to ensure proper medical care for the patient, to stop the harmful eating disorder behaviors, and help the patient work through the underlying issues. So currently, there's one residential treatment center, Center for Change in Utah, that's contracted with the Alaska State Medicaid office to provide benefits. So the criteria, who they work with and who would fit these criteria is female patients between the ages of 13 and 21 in need of higher level of care. And if you have someone with that, patient who fits those criteria, you should be able to work with the Medicaid office to get a referral to this facility. Jenny and I and others at AKEDA are, one of our goals is to hopefully get Medicaid to be able to expand that so that others can get the care they need. The next level down is a partial hospitalization program that provides about 8 to 10 hours a day of support. And again, it's geared toward decreasing the eating disorders behaviors, but allowing the patient to start to be able to live their life without having the 24/7 supervision. There's intensive outpatient, that's 3 to 5 hours a day of treatment. And then there's still some therapeutic and meal support at that level. The outpatient support is regularly scheduled sessions once a week or twice a week with a therapist, a dietitian, maybe a little bit less frequently with a doctor. That is the only type of treatment available at this time in Alaska. If you want to know more about the details of who would qualify for each level of care, there's information at the bottom of this slide, which is, and these level of care guidelines were developed by the American Psychiatric Association. Come on, Jenny, you're muted.
Thank you. So one of the interesting things about eating disorders is that they are both a physical illness, but they're also a mental health illness, and they also really require management of food as part of the treatment. And so as a result of that, eating disorders really benefit from having a trained professional team where each of the members of the team has knowledge about working with individuals with eating disorders. It's really important to know that eating disorders rarely go away on their own without some kind of intervention. So working with at least some members of these teams really can be integral. So who would be members of this team? Well, an ideal team would include a medical professional. So that would be somebody who really has knowledge to be able to monitor the patient's physical stability. As Beth had mentioned, eating disorders can change really quickly. And so making sure that we're monitoring the stability of the physical health is really important. Also, it would often include a psychiatrist who can help to manage medications if needed. Often a therapist who can help the client to work through the psychological aspects of the illness and also work on any co-occurring conditions. A dietitian can be an extremely helpful member of this team. They can help make sure that the nutritional intake for this patient is adequate and help the patient to work through all of the food-related anxieties that they are undoubtedly experiencing and challenges to help them return to normalized eating. The last member of the team is usually family members and friends. It really can be important to have people who can provide that practical support at home, provide that empathy, that encouragement, that belief that they can recover. So it's important to think that within this, each discipline really adds an important piece of the puzzle for a patient. And what we do know is that patient outcomes really are improved when there are members of the team. Those members are willing to come together, work together, collaborate, share information, and really engage in treatment planning together. We know it's not easy to find all those members of that team here in Alaska, but it is the ideal. And so it's something we like to encourage people to attempt to achieve. So once we have somebody identified as having an eating disorder, really one of the primary goals at the very beginning really becomes nutrition, nutrition, nutrition. Oftentimes in eating disorder, in the eating disorders field, we'll say that food is medicine. And so just like other medicine in eating disorder recovery, the food is the medicine and the food will be dosed. Most patients will be prescribed 3 meals and 3 snacks daily in the beginning. And the prescription will really specify the size of the meals, the variety of foods to be included, the quantity of foods to be included. The dosing will also include a timeline for the meals and snacks, usually so that there's no more than about 3 hours between meals and snacks during the patient's waking hours. And I will just say this is where having a dietitian as part of the team can be really helpful. They can help assure that the patient really is having a proper nutritional intake while also helping to make sure that the patient is really increasing in their flexibility to eat different kinds of food and to work through their fear foods. So you might wonder, what is the goal that comes from this kind of food prescription? Well, we know that some patients who have eating disorders will require weight restoration. And so for those, but even for patients who don't require weight restoration, the clear meal plans, the structure around meal times, it really helps patients to decrease the food anxieties that they might be experiencing, which really can help them to both allow their body to recover from the harmful behaviors and to start changing the behaviors that have gotten them there. And what we know is that with that sustained, sufficient nutrition over time, many of the physical impacts of the eating disorder on the body really can be mitigated or reversed. So, and then over time, the proper nutrition also helps improve mood. It helps them improve social interactions. And really importantly, it helps to the brain to be able to work more flexibly, which really does help people to engage more deeply in the cognitive changes that are needed to achieve recovery. I don't know if any of you know this, but a starved brain is a really rigid brain. And so until that nutrition comes on board, it can be really hard to make the further changes that are necessary. So I just want to say that if you do not have an eating disorder, you might think that this prescription does not sound terribly difficult. But we would just want to acknowledge that if eating were easy for these individuals, they would not be in your office. And the mortality rates that are associated with these illnesses would not be so high. Being able to complete a meal plan, especially in the beginning, is an incredibly difficult step for most people with an eating disorder, and it brings up really all of their deepest fears. So as a result, we like to tell people that they really will probably benefit from having meal support, having specific strategies that can help them to complete their meal plans and can provide both the assistance to complete it as well as the accountability to know that they are completing their food prescription. This stage of recovery also really prioritizes the cessation of eating disorder behaviors. So on a broad level, this means trying to stop those behaviors of the binging, the purging, the restriction, maybe excessive exercise. These are often what we refer to when we say eating disorder behaviors. But also know it also includes trying to really cease any food ritual that a person may have begun during the course of their illness. Really, the development of these rituals is quite common amongst those with eating disorders. It can include things like microbiting, where a person is really eating only these very, very small bites. It can also mean cutting food into very small pieces, maybe obsessively reading food nutrition labels. Sometimes feel the need to, people will feel the need to weigh their food or use very exact measurements. Sometimes they'll use unusual use of utensils or excessive chewing. These are just a number of some of these kind of behaviors or rituals that oftentimes show up in somebody with an eating disorder. So at the beginning, as the person is getting that nutrition on board, we're also really working on them with them to really return to normalized eating habits rather than allowing these disordered habits to continue. And I want to just say again, ceasing these behaviors is really, really hard work. And so patients often really do need a lot of support. Sometimes somebody to help provide accountability that those behaviors are stopping. And so at the end of the day, what we find is that if a person is unable to minimize or cease those behaviors using their community resources, that's often a time when recommendations might be made for a higher level of care where that 24/7 supervision and accountability can be provided to help somebody to stop those behaviors. And sometimes people will ask us if we believe that it is possible to achieve full recovery from an eating disorder. And Beth and I, we mentioned that we both had eating disorders ourselves, so we are living proof that it is possible to achieve full recovery. But what we like to tell people is that it's not always a straight line. And you can see that in this slide. Sometimes, as it is with many mental health conditions, you might have 3 steps forward, 2 steps back. And because of this, having some relapse planning is really an incredibly important important effort for this population. And we like to also just share this information with clients and their families to know that full recovery can happen, but it might take months, even years. It might be a marathon and not a sprint. And knowing that when you're going into it can really help to just let people know that the work is worthwhile. And you might wonder, how do we know if somebody actually has achieved recovery, a full recovery? And the field of eating disorders has been working on this question, and they just recently actually came up with a really great general consensus on the definition of full recovery from an eating disorder. And it really includes making sure that a patient has achieved recovery in 3 main domains. So the first of those domains is physical recovery. So that includes stabilizing the physical effects of the eating disorder on the body. We can measure that by things like, are they weight restored? Are their electrolytes and lab values back to normal? Have they resumed menstruation, if that's something that's applicable? And really making sure that we're addressing any other health conditions that have been caused by the eating disorder. The second domain of recovery is that behavioral recovery. So that means a cessation or dramatic reduction in those eating disorder behaviors, whether that's restriction, binging, purging, overexercise, all of those things that we just talked about on that last slide. And it used to be that if somebody had achieved physical behavior and had stopped and ceased those behaviors, that we thought, well, okay, they've now recovered. But the recent studies really show that those are only 2 out of 3 of the main domains that need to be where we need to see full recovery. And that if somebody stops recovery after the physical and behavioral pieces have recovered and stop there, that they may achieve what we kind of call a pseudo recovery. They may be walking the walk, they might be walking the walk of doing the right things, but internally, they're still talking that same disordered talk that they've talked to themselves. Things like, I'm not good enough. Oh, I should be starting that behavior again. So they're still having those same thought behaviors. So what we like to say is that if you stop at the physical and behavioral pieces of recovery alone, that person is still probably at a high risk for relapse. And so what we encourage people to do is to really work with their entire team and continue to work so that they can achieve also that psychological mental recovery. And that means making sure that they're working on issues like body image, distress, perfectionism, rules around eating, and the emotional issues that have gone in it. And it's really folks who work on all 3 of these pieces of the domain where we see full recovery happening and a decrease in the rates of relapse. So there are a number of modalities of treatment that are often used in combination with eating disorder treatment. We are not going to try to talk about all of these, but it's good to know that there are evidence-based methodologies that a therapist will usually work with somebody to help them achieve that full recovery that we just spoke about. And we always like to include resources so that people know where they can go to find information. If you are trying to help somebody find a higher level of care outside of Alaska, we encourage people to use the findedhelp.com. They have an interactive database that can help people find facilities, and you can also call, and there are postdocs who answer the phones and can talk through best options. The AKEDA website here also includes a growing list of providers here in Alaska who can work with patients with eating disorders. And then there's also the Project HEAL, which we include here. They provide some scholarships for people who do not have access to resources to get into treatment. They are more limited than we would like, but it's the best that can be done. But Project HEAL also has some really great resources for full assessments. So if you have a patient who's really trying to get a full documented diagnosis, this is a great place where they can go get a free assessment.
And so we're going to quickly go through a little bit of information about resources here in Alaska, and then we'll save some time for questions. One of our primary goals is to increase capacity within the Alaska healthcare system to understand and be able to address eating disorders. So if you're a provider who wants to continue education, here are just some of the things that are coming up. We'll talk about a few more too, but we do have these webinars available. We have a webinar by Dr. Jennifer Gaudiani on medical management and of eating disorders in outpatient settings, and one specifically for the pediatric population. In April, from April 26 to 28, we'll have a training on temperament-based treatment with supports, which is a strength-based approach, understanding how someone's temperament can be used, that may have been used to advance an eating disorder, can be shifted to help a patient recover. That will be, we expect to have 24 CMEs and CEUs for that one, 3-day training. And we have an on-demand eating disorder boot camp with a nationally known presenter, Jessica Setnick, and that is 7.5 CEs. And then we are going to have some continuation of the Alaska Eating Disorders Project ECHO that we offered in 2022. We will have a couple of pop-up Project Echoes, one on people in higher weight bodies and bariatric surgery and eating disorders. We're going to have one on avoidance food restrictive intake disorder, or ARFID. And then this fall, we'll also have some additional Project Echo sessions. So we have an education and consultation group that takes place the second Tuesday of the month from 12 to 1. This is free. It's available for providers from around the state. People can bring cases for consultation in this confidential session, this confidential consultation group. And it's facilitated by Dr. Melissa O'Neill, who is a certified eating disorder specialist and supervisor. And so this is open to doctors, therapists, dietitians, and really anyone who works with clients with eating disorders and would like to know more. Here's a Zoom link. If you're interested, you can also reach Jenny or myself. We have 2 support groups. One is for family and friends who are supporting a loved one with an eating disorder. So again, if you're a provider and you're speaking with parents, spouses, partners, this is helpful to share with them. This is held the 3rd Saturday of the month via Zoom. And we have a licensed professional counselor who facilitates this and offers helpful psychoeducation as well. We also have a group for adults with eating disorders. So for those who are 18 or older, and that takes place every Thursday night from 5:30 to 6:30. And so these are free and confidential. And here is our social media. You know, there's so much social media that's out there that can be focused on diets and on reducing weight and can be incredibly triggering. So we encourage you all to follow us on social media and also to encourage others, because this is recovery focused social media. On our website, there is quite a bit of information about eating disorders, about providers, about resources. And all of our trainings will also be listed on there. So we encourage you to take a look at that. And here is the website link, Jenny's link, my link, or our emails. And we just encourage you to be in touch if you have questions. We really do want to connect with people and expand our alliance of people who are interested in addressing eating disorders in the state. And I'm going to stop the screen share so we can address any questions that may come up.
Yeah, thank you so much, Jenny and Beth. I'm going to stop the recording so that if people do have more sensitive questions they want to ask, they can ask those without being recorded.